Thank you for the invitation and to open this session with a hot topic on EGFR TKI resistance and novel treatment strategies. Some background: EGFR mutation are observed in about 10% of metastatic lung adenocarcinomas. The two frequent mutations are exon 19 deletions and L858R mutation in exon 21 encoding the kinase of the EGF receptor. In this situation, first-generation TKIs, Gefitinib, Erlotinib, and Afatinib demonstrated benefit as compared to platinum-based doublet chemotherapy in the first-line setting, with median PFS ranging from 9 to 13 months in those trials. So resistance inevitably occurs in this situation, and I will focus on acquired resistance that is different than primary resistance. Response rate to EGFR TKI is about 80%, so a small subset of patients, 20%, may do not respond to those drugs, and it may be related to compliance issues, pharmacodynamic interaction, and possibly polymorphism in apoptosis-related genes. I will focus on acquired resistance, meaning resistance occurring after an initial response to the TKI. We have different clinical profile in this situation, and we have to distinguish systemic progression, meaning the growth of multiple lesions, pre-existing or new lesions in the lung, in the brain, or other organs. We have to distinguish systemic progression from oligoprogression. Oligoprogression occurs at one or a limited number of sites, again, on a pre-existing or a new lesion at time of progression. The management of oligoprogression is different from that of systemic progression, and it's common sense that in the setting of oligoprogression, patients receive local treatment. And we now have a body of evidence showing that it's of interest to have a local treatment for the oligoprogressive disease, together with the continuation of the TKI, which may lead to increase the PFS of 4 to 7 months in this cohort of patients. What are the criteria to define oligoprogression? This is highly discussed topic. We can consider such a strategy in the setting of CNS progression without leptomeningeal disease, and in the situation of up to 4 extra CNS sites amenable to local therapy, which may consist of surgery, stereotactic body radiation therapy. Slow progression is another clinical profile in the setting of acquired resistance, and we now have some data also for slow progression, suggesting the interest of continuation of the TKI beyond resist progression. We have now data published of the Aspiration trial. Aspiration was a trial conducted in EGFR-mutant lung cancer, Erlotinib first line, and a prospective study that compared the PFS according to resist progression to PFS based on the clinician assessment. And you can see that the PFS was increased by 3 months when continuating Erlotinib beyond resist progression. In those patients, you had some patients with oligoprogressive disease who received local therapy, but also patients with systemic progression, but a slow-growing progression. My recommendation when continuating a TKI beyond progression is to have a close follow-up of patients to avoid missing the time of rapidly growing, rapid progression requiring second-line treatment. Systemic progression, the standard treatment so far has been chemotherapy, cisplatin-based or platinum-based doublet chemotherapy, as reported in the IMPRESS trial. IMPRESS trial is a study that compared the continuation of Gefitinib to placebo in addition to platinum-based chemotherapy for patients presenting with acquired resistance to Gefitinib. This trial was negative for its primary endpoint, but what is of interest with those data is that the response rate and the PFS rate with platinum pemetrexed in the setting of acquired resistance were actually similar to what is observed in the first-line setting. So when switching from a TKI to chemotherapy, the recommendation is to use a platinum-based doublet. It's obviously better to focus on the mechanism of resistance, the molecular mechanism of resistance that may be observed at the time of acquired resistance. And those mechanisms are multiple, and three major groups of molecular mechanisms to acquired resistance have been reported so far. The most frequent is the occurrence of an additional mutation in the same pathway, meaning the development of a T790M clone within the tumor that continues to activate the EGFR signaling pathways, but limits the efficacy of the first-generation EGFR TKI. The second mechanism is bypass, meaning that there is a switch in the tumor cells from the EGFR signaling pathway to another pathway, RBB2 pathway, MET pathway. Another mechanism is transdifferentiation. It's pretty rare, and it consists of the transformation of EGFR-mutant adenocarcinoma into small cell lung cancer. It's important to understand that those resistance mechanisms that constitute the bulk of the tumor at the time of progression may actually be observed in the initial tumor in a small subset of tumor cells, meaning that if you use sufficiently sensitive techniques to identify all the subclones that are present in the initial tumor, you may identify the major clone, which is the EGFR-mutant clone, but also in a small subset of tumor cells, the clones harboring the resistance mechanisms. So at the time of acquired resistance, to identify the molecular mechanism of resistance, rebiopsy is mandatory. Is it feasible? Yes. This is the results of a French collaborative study showing that rebiopsy is feasible in about 80% of patients. But when you do a rebiopsy, you have to choose a target lesion. So you will use the lesion that is accessible or a lesion that is rapidly growing. But you have to keep in mind that the resistance mechanism may be different in one lesion from one lesion to another. In this cohort of patients, T790M mutation was far more frequent in thoracic lesions as compared to CNS lesion. So maybe instead of choosing one lesion to rebiopsy, it's better to have a global view of the disease using new techniques, liquid biopsies, mostly consisting of the analysis of circulating free DNA. When you do that, instead of cutting one branch of the tree, you just have to pick up the leaves, and you will have a global view of the mechanisms of resistance that are present in the primary tumor, but also in all the metastases, because you will take all the DNA, the tumor DNA, from those lesions. What to do at the time of acquired resistance? Maybe one idea could be to switch from one TKI to another, Afatinib to Rociletinib to Afatinib. It doesn't work. It doesn't work. When you do that, the results are far lower than that of chemotherapy. So this should not be done. Another strategy that has been investigated is dual inhibition of EGFR using a TKI, Afatinib, and Cetuximab, which targets the extracellular part of the receptor. We have some interesting and promising data from this phase 2 trial showing that dual inhibition may be of interest in the setting of acquired resistance, but these results should be confirmed in clinical trial, and the French intergroup is currently running a trial testing the combination of Afatinib and Cetuximab in this situation. Maybe of higher interest to target exactly the mechanism of resistance, and I will spend some time on T790M. T790M is the most frequent mechanism of resistance to EGFR first-generation TKI. It's observed in 60 to 70% of patients at the time of acquired resistance. And we now have specific TKI, third-generation TKIs, that primarily target T790M. One of those TKI is AZD9291, osimertinib. And you can see that the profile of this drug is completely different than that of Afatinib. Primarily, the drug targets T790M and EGFR mutations, and the drug does not target wild-type EGFR, meaning that the side effects are far lower than what is observed with first-generation TKI. We have data from this first trial, phase 1 trial, published in 2015. You can see that the response rate, 61%, the PFS, median PFS, nearly 10 months, is pretty similar to what we have in the first-line setting with first-generation TKIs. On the contrary, the drug is completely ineffective in T790M negative patients. So it means that if you want to use AZD9291 in the setting of acquired resistance, you need to identify T790M and then rebiopsy or do a liquid biopsy to identify this mutation. Osimertinib is now approved by the EMEA in the setting of T790M positive lung cancer. Another TKI, third-generation TKI targeting T790M is Rociletinib. Rociletinib has a similar profile than osimertinib. Again, a phase 1 trial showing a promising response rate and PFS rates in the situation of acquired resistance related to T790M. Rociletinib may also have some effect in T790M negative patient with a response rate of 35%, and this may be related to off-target effects, as the drug also targets IGF-1R, which has been reported previously as a mechanism of resistance to EGFR first-generation TKIs. One question is whether those third-generation TKIs should be administered in the first-line setting, similar to what we do with antibiotics. We try to use antibiotics that cover all the resistance mechanism, but in this situation, then you have to demonstrate that the third-generation TKI as a first-line treatment will do better than the sequential approach with a first-generation TKI and then a third-generation TKI. And clinical trials are actually ongoing in this situation. We have some preliminary data showing that third-generation TKI are of interest in the first-line setting, but we are still awaiting for the results of those studies, both with osimertinib and Rociletinib. Actually, the next issue when using third-generation TKI will be the resistance, because those third-generation TKI will be effective for a specific period of time, but at some point, resistance will occur. And we already have some data regarding the mechanisms of resistance to third-generation TKI, especially with osimertinib. And one frequent mechanism of resistance to osimertinib is the emergence of a subclone harboring another EGFR mutation, which is C797S. C797S mutation occurs at the time of resistance to osimertinib, but there is here another level of complexity, which is the location, the exact location on the DNA of the mutation. C797S in red may be observed on a different allele than the T790M in blue, or on the same allele. And to know that, you need to use highly sensitive sequencing techniques. But there is some clinical relevance there, because preclinically, if you look at cell lines, you can see that if the C797S mutation is located on a different allele, you will have some effectiveness of re-challenge with Afatinib. So maybe in the setting of a patient treated with third-generation TKI, then osimertinib, emergence of C797S, you may re-challenge a patient with Afatinib. So you can develop sequential approaches using the TKIs that are available, but the algorithm is becoming more and more complex with the necessity to identify whether the resistance mutation are on the same allele or a different allele on the DNA. So it increases the level of complexity of the management of patients. Interestingly, with Rociletinib, the mechanisms of resistance seems to be a little bit different than that reported with osimertinib, and the most frequent molecular event at the time of resistance to Rociletinib is related to the loss of the T790M mutation, meaning the loss of the clone harboring the T790M mutation. So maybe some differences related to the drug by itself, but it also may be related to the sequence. And again, if we look at some preclinical data, we can see that in cell lines, the resistance mechanisms are different depending on the delivery of the third-generation TKI upfront or after the administration of a first-generation TKI. So what does that mean? It means that if you use a third-generation TKI, osimertinib, Rociletinib, in the first-line setting, maybe the molecular events in the tumor will be very different than the molecular events that you may observe if you do first-generation TKI and then a third-generation TKI. So we have to understand what is the best sequence, also based on the resistance mechanism, which are different depending on the treatment sequence. So this was for T790M. We have other mechanisms of resistance consisting of bypass. The most frequent bypass is actually the amplification of MET. So it's observed in 3 to 10% of tumors at the time of acquired resistance to first-generation TKI. We have some data showing that crizotinib is effective in this situation. It's more effective if the amplification of MET is higher. So again, a need for a quantification of the amplification of the MET gene. Transdifferentiation is very rare, less than 5% of patients. Transformation into small cell lung cancer, and this mechanism is very important to keep in mind because it can be identified only if you do a biopsy. If you do liquid biopsy, you will not identify small cell lung cancer. Chemotherapy based on platinum etoposide is effective in this situation. Interestingly, the transformation into small cell lung cancer is related to a single molecular event, which is a loss of RB1, and loss of RB1 is well known in small cell lung cancer overall. So this is a mechanism, molecular mechanism, that leads to a specific morphological appearance of the proliferation. So targeting resistance is becoming more and more complex because of T790M, because of the global strategy and the sequence of treatment. But we also have to keep in mind that we need to consider the microenvironment in this situation. We have some data about angiogenesis inhibition in EGFR-mutant lung cancer, results of this Japanese phase 2 study showing that if you combine erlotinib with bevacizumab, anti-VEGF-A antibody, you will increase the PFS of a patient by 7 months as compared to erlotinib alone. In this study, the PFS with erlotinib-bevacizumab combination was 16 months. And the results have been somehow confirmed by this prospective European phase 2 study. It's a single-arm study combining erlotinib plus bevacizumab. And again, 16 months PFS was reported, interestingly, specifically in patients presenting with T790M de novo mutation, meaning a small subset of the tumor harboring T790M mutation. We also have data about immunotherapy in EGFR-mutant lung cancer. The interest is to combine the high response rates to the TKI to the prolonged duration of response provided by immunotherapy, and this is preliminary data. We clearly need to look at clinical trials in this situation. So we need to consider the strategy overall, and this is very important for the patient because the survival of EGFR-mutant lung cancer patient treated with targeted therapy is about 4 years. So you need to deliver all the therapeutic options in a good sequence to avoid missing a chance for the patient. Targeting resistance is a modern way to do the treatment of acquired resistance, targeting T790M with specific TKI, but we need to know whether continuation beyond progression is of interest and at which time of the strategy. And again, chemotherapy still has a role in this situation, together with the targeting of the microenvironment. I thank you for your attention.